So I will let Giacomo take over.
Thank you. Welcome to all. Thank you very much for being here in this TGCT track session. I'm a medical oncologist. I'm based here in Italy, in Prato, a small city close near to Florence, and I'm happy to host this annual meeting here in Italy. And first of all, I would like to thank the SPAGN, and of course, a huge thank you to Sydney for inviting me to this TGCT track to speak about the do's and don'ts of systemic therapy in TGCT. In my opinion, is a fascinating but challenging title, and I will try to do my best in next minutes to share my thoughts with all of you. Sorry. This one. Okay. These are my disclosure. And so I'd like to start again with the consensus document on the best clinical management in TGCT. This document was published last year within all the community of the experts in the disease, together with the patient. And I would like to thank Dr. Silvia Stacchiotti and Dr. Sebastian Bauer from Italy and Germany to coordinate this effort. And of course, a huge thank you also to the patient advocates from SPAGN, Catherine Schuster, and again, Sydney for coordinating this from TGCT support. In this document, as a community of experts, together with patient advocates, we try to address the open questions in the disease, try to harmonize treatment within all the referral centers, but of course underline also the remaining uncertainties. The document, again, thanks to the effort of Sydney, was then adapted in a patient-friendly version to get more clarity for patients about the best management of TGCT, and was then translated in different languages to reach the broader patient community worldwide. In the patient-friendly version of the document, you can find this algorithm that is not reported in the consensus document, and we have prepared this algorithm just to get more clarity for patients about the management of TGCT. And I would like to start from this figure just to say again that the majority of patients suffer from the nodular form of the disease that can be easily removed by surgery, as we can already say, and that medical treatment is only be for particular clinical situation in diffuse type TGCT, the rarest form of the disease. And I think that this is an important takeaway message. Only a minority of patients require a systemic treatment for TGCT. Of course, as a general message, each systemic treatment should be managed in a multidisciplinary meeting with all the experts of the disease that can be balanced the risks and the therapeutic benefits of each treatment. And then we have to share with our patients the objectives of treatment, to discuss with our patient the dose of treatment and the expected potential toxicities of each treatment, since we are facing with a chronic disease. And of course, on this we can explore different strategies like the stop and go one, for example. And again, I would like to start with two clinical cases that have been managed in my hospital, just to explain with you what is the do's and don'ts of systemic therapy in TGCT for me. The first case involves a male patient of 27 years old that, for persistent dizziness and nausea, performed an MRI showing an expansive lesion in the left basal and polar temporal area, involving the tympanic cavity and infratemporal fossa, with also involvement of the mandibular condyle. Patient in another institution performed in 2021 a debulking surgery with a pathologic diagnosis of diffuse type TGCT. Then followed up. In December 2021, patient presented to our institution for swelling and jaw pain onset, and an MRI showed a progressive disease in the same location of the previous surgery. We, of course, discussed the case in our multidisciplinary meeting, and we were faced with a patient asymptomatic or mildly symptomatic, but he had progressive disease in the last 6 months. And of course, surgical in this critical anatomic location will be very morbid. And patient had a very high risk of life-threatening disease, since the lesion was very close to the skull base. And this is the reason why, in this case, we propose to a patient to do a medical treatment. Patient in February 2022 started with imatinib at the dose of 400 milligrams per day, experiencing an improvement in symptoms after the first month of treatment. And this is the first MRI scan showing a nice response at the first disease assessment. And as we state in the consensus document, an active systemic treatment may be justified in the rare asymptomatic cases like this one, in which anatomic location is potentially life-threatening. Of course, for example, in the location in the spine. And it's worth to note that this patient is still under treatment with imatinib, with a very good quality of life, in a very good condition, no symptoms, and with a maintain of the response at the latest radiological assessment. Why we choose imatinib for this patient? In this table, I try to summarize which are the activities and the efficacies of systemic therapy for TGCT, mainly imatinib, nilotinib, and pexidartinib. But it's worth to note that pexidartinib can only be prescribed in US, since it's not approved for the clinical use in Europe, and unfortunately, imatinib and nilotinib are not approved and can be prescribed only off-label. These are the results with imatinib of the long-term efficacy results of the previous retrospective study published in 2012. Imatinib was the first drug studied in the disease, and these are the results on 62 patients retrospectively collected from 12 institutions in Europe, US, and Australia. And as you can see in the table, imatinib confirmed the good activity in the disease with a long-term activity. The median imatinib duration for the patient in the study was 9 months, and the median progression-free survival was 18 months. Of note, 24% of patients discontinued the treatment in this analysis by choice. Similarly, these are the results with nilotinib. Nilotinib was studied in 2018 in a phase 2 prospective studies in TGCT. These are the long-term follow-up results on 48 patients enrolled in this phase 2 study. And as you can see, nilotinib confirmed the activity as at a long-term follow-up, especially in terms of stable disease. And again, here, 29% of patients discontinued the treatment by choice. And finally, I would like to show this pooled analysis about the result of all the patients with TGCT enrolled in the studies with pexidartinib. The phase 3 study, the ENLIVEN study, the registrative study of pexidartinib in TGCT in US, and the patient enrolled in the phase 1 expansion phase study with TGCT. And as you can see here, the authors confirm the very good activity of this drug in the disease, with an overall response rate of 60% when you use RECIST, and 65% when you use a tumor volume score, that is another endpoint that was studied in this trial. And this activity was maintained over time. And here again, 15% of patients withdraw the informed consent from the study, and 4% of patients discontinue the treatment since they are non-compliant to the study procedures and study treatment. And I think that this is important to highlight, because despite the high activity of these drugs and the long-term activity of these drugs, treatment are challenging for patients and open the the way for new treatment strategies like the stop and go one that is objective of ongoing clinical trial in TGCT. And in the consensus document, again, we state that CSF1 receptor inhibitors, imatinib, nilotinib, and where available, pexidartinib, are considered the standard of care. But since pexidartinib is only prescribed in the US and imatinib and nilotinib are not approved for the disease, when available, clinical trials should be offered to our patient. And later we will talk about the clinical trials now open for the accrual for the disease. Move forward with the second clinical case. This case involved a female patient of 61 years old that in May 2018 performed a surgery for a left ankle swelling increasing in size. Patient underwent an anterior and posterolateral open synoviectomy with a pathological diagnosis of diffuse type TGCT. In August 2019, patient presented to our department with an ankle lesion of about 7 centimeters, as you can see here in an MRI scan. And we discussed again the case in our multidisciplinary meeting. We were faced with a patient with a progressive lesion, a big lesion in a small joint, but she was asymptomatic. She could walk for long distances only wearing comfortable shoes. And she hadn't clinical limitation of joint range of motion, and she hadn't pain in the joint. And this is the reason why we decided to don't propose to patient a systemic treatment, but start with active surveillance. In August 2019, patient started with active surveillance, and she remained on active surveillance with a good quality of life, without pain, without symptoms for 3 years, performing only an MRI every 6 months. Then in September 2022, patient progressed with symptomatic disease, and we proposed to start a systemic treatment. And again, in the consensus paper, we state that in asymptomatic disease, active surveillance is the initial preferred approach, as the risk of overtreatment appears to outweigh the potential harm of delaying systemic treatment. But of course, this statement should be adapted case by case, because we can have different cases. Again, I would like to show you this work that for the first time was published this year, a few months ago, and for the first time this paper explored the role of active surveillance in TGCT. This study involves 61 patients, retrospectively collected from 8 referral institutions from 2000 to 2019. It is important to note that some of these patients, as you can see here in this table, were symptomatics for pain or swelling, and some of them need to use chronic analgesics for control the pain related to the disease. And interestingly, at the median follow-up of 28 months, as Emanuela already said, 55% of patients had no radiological progression. And again, interestingly, 21% of patients improved their symptoms during active surveillance, and only 1 patient in this series needed to start a systemic treatment, with a median time to start treatment of 21 months. And this is, in my opinion, a very interesting result, since the median progression-free survival of patients on active surveillance in this study was 50 months. And this is something that we can discuss maybe later in the Q&A session. And these results are consistent with what the top registry already demonstrated. Emanuela already presented this observational prospective study, and on this study, about 70% of patients, of the 79 patients that start with active surveillance, are free of radiological progression, let me say free of treatment, or at 2 years from the start of active surveillance. So, what are my take-home message for you as a patient community? What are the do's and don'ts of systemic treatment in TGCT? Generally we propose a systemic treatment in symptomatic patients with progressive disease with a worsening of quality of life, and when surgery is no more feasible, or if feasible but with unacceptable morbidity for patient, and as I shown with my clinical case, in critical anatomic primary location where patient can have life-threatening risks from further progression. When we don't propose a systemic treatment to our patient in asymptomatic and non-progressive patients or mildly symptomatic patient, because symptoms can be under control with the use of analgesics, for example, or often pain can be related to the osteoarthritis and not to the TGCT, that is a medical condition that is often associated with TGCT, as Emanuela already showed to us. And of course, when there is a risk of major morbidity from systemic treatment. But I think that the most important take-home message, as my colleagues already said, is that each single case from the primary diagnosis should be managed in a referral center within a multidisciplinary meeting with experts of the disease. Each decision, each treatment should be balanced, and we have to balance the risk and the therapeutic benefits of each treatment. And again, the decision should be shared with the patient. Patient have to take part in the decision-making process. And of course, the first goal of our treatment should be the quality of life, since we don't forget that TGCT are benign lesion, even though locally aggressive. And first of all, I would like to thank my patients, since they give me the opportunity to share with all of you their experiences in the disease, and I would like to thank you for your attention.
Maybe dead.
Yeah, I think, I don't know.
We have a red button. Red means bad. Red is good? Okay. Well, thank you very much. Does anyone have any questions? We're a little ahead of schedule. I'm going to keep you up here, Dr. Baldy. I'll say no, and then I'll let some experts say it. There's no risk factors associated with TGCT. Majority of people are between the ages of 20 and 50. That is an age range in which you are more athletic, but they're not related generally. I don't know if I will let them agree, disagree. Cool. Yes. It's bad.
As I sit here, I think one, especially coming from an area in which I had zero knowledge of this. So, but my question is, because I read a lot on the Facebook page, and the question is, are doctors in general taught in medical school about a TGCT? Do they have specific understanding? Is that
No, no.
because so many patients,
Yeah.
so even when I went through my situation, I was at Weill Cornell and they said they're what is it called? Some type of cyst. Yeah, the cyst. And then they said, but the nurse practitioner and the radiologist were very clear. She said, you're a melanoma patient. There's an added situation here, so we think we should go further. And then they did. And then they sent me over to MSK, who I was in the good hands of. But many of the doctors I find don't even know of this or know the exception to the case of it. They know sarcoma. Sarcoma's out there. But I think because it's benign, maybe it's not even treated as a real thing. But when I hear the stories of I have no pain with mine. They're in my wrist, zero pain, range of movement is fine. I consider myself extremely lucky. And the vimseltinib is keeping them at base. But when I see the pain and what goes on with these patients, and I'm thinking, if they had gotten to the right doctor initially, so that's where my empathy lies is, are they learning about this in medical school so that they would have an idea how serious it is? It's so serious.
No, yeah. As you underscored, there is a great difference in between malignant and benign, because benign usually we did some patient journal publication to underscore that patient never used to go to a sarcoma center, and they used to go to a general practitioner, rheumatologist, and then maybe orthopedic surgeon that would always operate on that. But thanks to Sydney and thanks to all the evidences that were created over these last 10 years, this has improved much. I work in an orthopedic hospital, like there are just orthopedic doctors in Istituto Ortopedico Rizzoli, and I saw clearly from 2015 when we launched the pexidartinib trial and nobody would refer patient. Now they knows that the oncologist also take care of that, and they would refer or discuss us. But medical school, yeah, I think it's super specific for that kind of.
Most doctors, particularly in the US, and I can probably speak for the countries here, they learn it in residency or your post training where you are already interested in oncology. And so, as you can see, you will meet amazing doctors at referral centers. But if you do not have a referral center, contact me and I can help you find one.
Yeah.
That's, I think
I would say the same, Sydney. Yeah, because I think it's true. It's a benign lesion. Okay, but I saw a lot of patients with a very advanced situation in my clinic, and they told me, "Oh, my orthopedics tell me that it's a benign lesion. Why it happens?" So we have to be aware of this and try to send the patient the right place for the disease. And I think that the work of Sydney and all the patient advocates is very important for this. Thank you.
yes. So,
Thank you.
die to get there.
Okay. Okay, because I already heard a lot about systemic therapy and about open surgery, about synovectomies, but I'm wondering, are hip joints prostheses used for diffuse TGCT treatment?
Especially in the hip. Yeah.
Yeah, especially in the hip because, yeah.
First of all, we have to say that not a lot of patients need a prosthesis. This is the first thing. I know that this is possible, but this is not the majority. This is the first thing. So what I said before, it's not correct if we, as orthopedic surgeons, tell patients with this disease, we have to make surgery each year in order to avoid arthritis. This is not correct. This is not correct. In the hip, I have now a weak point. I have not the studies present, but for the knee, I can tell you that we know that if we need a knee prosthesis first, we need it because of arthrosis, because of erosion of the joint. You sometimes have to make, as we say, bone supplementation, augmentation with grafts because you have cysts in the joint. These are really big surgeries, and sometimes you need not a normal arthroplasty. You need an arthroplasty which is a fixed hinge joint because you have to sacrifice the ligaments and you have to bring in like a tumor prosthesis, you can say, not in the end form, but it's really a big surgery. And what we know out of these surgeries, knee first, is that we have also in these cases local recurrences, because also in these cases you cannot remove all of the tissue, because then you have a diffuse type. And what we have not discussed before, if you have a diffuse type, what is the distinction between extra-articular and articular TGCT? If you have in the diffuse type, this tumor can go from the joint in the muscle. You cannot define it, and therefore you have often so much bleeding, because this is there is not a separation. Here's a joint capsule and here stop. This is not true in the diffuse type. So if you make an arthroplasty, if you have to do it because of arthritis, because of changes of the bone, you have, even after an arthroplasty, a risk of recurrence. We have to say it. And perhaps also there, medical therapy has definitely its role. The second point is, which is really, this is not nice, that we have higher complication rates. Because as an orthopedic surgeon, I can tell you, if you get a primary knee arthroplasty, you have 1/3 of patients are brilliant, 1/3 say, yes, it's not bad, and 1/3 of patients say, oh, it's not so good. Normal arthroplasty. In this tumor entity, you have the problem that you have a lot of surgeries before. You have scar tissue, etc. And we know that the function is not comparable with normal arthroplasty. First, and second, we have a higher risk of stiffness of the joint, of arthrofibrosis, and of infection. It's not so rare. We know this in knee. In the hip, I apologize for it. It's not so often, but of course here also I would suggest that we have higher risk of infection, and that the prosthesis is not so good fixed, as I've shown you my case. There you have bone erosion. If you cannot put in a normal press fit, as we say, hip stem, you cannot put in a press fit hip socket. This means socket. The hardware of the acetabulum, because you have the problem. So this means you have to start for the first with a hip prosthesis, which is more revision arthroplasty, and then you have to ask yourself about the bone stock situation. This means if you put it in, and you put it in not as a primary, more than a revision, we know that the re-revision rate is coming, so that we are a little bit more. This does not mean that I ask, do you have a hip prosthesis inside, or not yet? Yeah, this is, this therefore I ask, and therefore I ask, because let me say like, we have a lot of patients with necrosis of the hip joint after AML and etc. in very young patients. We know it, and they have arthrosis a little bit, but they have a quality of life. And this is again decision making. If I would have a arthrosis or erosion, and I can say, okay, it's okay for me, I make physiotherapy, I make bicycling, it's okay, I would say not to do too early an arthroplasty, because we know that if you are 20, you know, with 35 the first revision, then the next, and then you are coming sooner or later in pelvic replacements, because the bone stock is not there anymore. So this does not mean that I would tell the patient, do not make an arthroplasty. Don't misunderstand me. But what is wrong to say, as I've shown in my case, we put it in easy, no problem. This is not true. We have to balance it. Again, burden, risk, and benefits. This is very, very important, because in my opinion, if you go to a traditional orthopedic surgeon, he looks, oh, everything is shit, I do it. But this is wrong. You need the oncological point of view, and your problems, your quality of life is in the middle of everything. And then you have to discuss, may I ask some question? What is your walking distance? Without crutches. Yeah. You walk with crutches. Yeah, then I'm honest that, yeah, this is one point where you have to discuss. This cannot be the aim in your age, to walk with crutches. Then we have to look if we can make, perhaps by medical therapy, some improvements. Because the question is, why do you have the problems? Because of the disease itself, or because of arthritis, or because of bone substance loss? In my opinion, first I would check medical therapy before I go to an arthroplasty.
Yeah, we we treated a couple of cases within the pexidartinib clinical trial of with HIP TGCT, diffuse TGCT, and they both went to surgery after response, which might also be an opportunity, but there are no very big data, so it's important to follow every case and get all the data on this tough location such HIP.
In our registry, which we're about to publish, people with replacements have higher recurrence rates in our database, if that helps. And that may just be an artifact of they've had more surgeries before it too, but it's something to consider. So if you're looking for any doctors, please let me know and I can help. Yes. Yes, please. We have a few more minutes.
Dr. Answer. What's the option of having diffuse TGCT quite late stage, I guess, and plus bone erosion and no medical therapy available yet? So what is next? What can I expect? Is it total knee replacement or is it wait? But
I understand. Again, my question: what is your quality of life? What would you say?
can for quite a bit of distance without scratches and yeah, pain and then
Okay, if you have no medical therapy option, if I understand it correctly, then no systemic. If you have no systemic treatment option, again, if we would have, I would recommend this. If we would not have, and you have a severely impaired quality of life, we have to do, in my opinion, surgery. We have no other possibility. We have to look: is the pain more because of the ventral part, more of the dorsal part, or perhaps also because of arthritis? Again, the pain can be explained by the tumor itself or by secondary arthritis. And this you have to look. And sometimes it makes sense to make an arthroscopy first, then you can try to remove the ventral part, and the surgeon can look how the quality of your cartilage is, So, and then he sees if the joint cartilage is completely destroyed, we are more or less then in the situation to make an arthroplasty. This means you need first a complete diagnosis.
like the size difference, and the X-ray doesn't show any. It's unchanged, they say so.
Yeah, but if the MRI shows no real cartilage defect, yeah, then you have to look if it's in the weight bearing area or not, and then you have to decide if you make an arthroplasty. But again, the first choice would be, in my opinion, if it's not completely destroyed, to make then a surgery. Medical therapy not possible. Then I would make first a surgery to remove what I can and to look what happens. I would not make the arthroplasty question is hard. I was really disappointed as I looked to the results of knee arthroplasty and TGCT. They are not good. They are really not good.
Go ahead, Steph.
Hi, thank you. Thank you so much for your presentation. I wanted to ask about the algorithm that was in the consensus paper that was shown a little while ago. Do you feel like there will be either an update to the consensus paper, as we know there's other treatments, and as we learn more about TGCT, could there be an update? And then the second part of my question is, do you see that translating into like a formal guideline? Like, for example, you have NCCN. What do you see happening next?
So I submitted last week NCCN guideline recommendations, actually. So yes, I know we will all organize an update, especially when some drugs become available. And then more trials will start, and so I think there will be continuous updates. I know we all, when we wrote it, we wanted to write it where it could be in real life changed over time. And we're already, NCCN is on my radar. So, so I think yes. Sorry, Stephanie, to answer your question. Yes.
Um, I have diffuse type in my knee and I had multiple surgeries. And my question is, I often get letters after the MRI saying that you can define if it's scar tissue or TGCT. So is there a way to actually define it, or is it actually that hard?
I'll let you have the hard one.
No, this question is easier than the questions before because there it's really difficult. I'm honest, and to make a decision. This is, in my opinion, relatively easy because if you say, "Oh, my quality of life is now good. I have a surgery," and even if it's a scar or it's a persistent lesion or a small recurrence, and you have not relevant problems, active surveillance.
Radiation. Does that change your answer? I'm just giving more.
If you have 5 surgeries and no, definitely not, then we have to make de-escalation. De-escalation. This is a problem. Again, I think that a lot of these patients, we are experts have an overtreatment, surgical overtreatment. They have a surgical overtreatment. If you have no problems, make wait and see, and nothing happens. If you have problems, you can do the surgery. But it's sometimes difficult to discriminate between reactive or scar tissue or if there is a small recurrence. How big should the recurrence be? If it's could you have a size, millimeters, centimeters, or?
Depends, like after I just had surgery again.
Yeah.
So now it's about 2 centimeters.
Yeah, honestly, often this is more than a small recurrence, let me say like this, because a scar is more diffuse, it's more flat. If it's more nodular, or we have to see the pictures then. But even if you have no problem, I would make wait and see and do nothing. So there you have to see the pictures, MRI, and then perhaps we could discriminate it even more easy. Yeah.
Okay.
But there is no real concern for me now.
It's hard to see it.
Yeah, if I would see the pictures, I can tell you 70% to 30% yes or no. Not definitely. Then you have to make histology again. But there are some clues that you say. For me, as a tumor surgeon, we look more, even in sarcoma, and nodular. Recurrence is mostly not flat. Edema is more a nodule again. And this is what we always discuss in our MDTs. Often we can discriminate it relatively good then, yeah.
Thank you. We'll take the last question and then we'll take a picture and I will let you guys consume caffeine. Oh, you didn't. Oh, even better. Oh, yes, absolutely. Yes, please, Mandy. Thank you.
Okay, so I'd like to ask the question regarding artificial intelligence. It's present in our life everywhere, and maybe it's my dream, but that during the synovectomy, the synovectomy could be run with support of artificial intelligence, just to remove the tumor at 100%. So there are any studies on that, or maybe it's...
So interestingly, actually, Leiden uses artificial intelligence to capture some of their MRI data to look at their tumor volume. Really effective at that. So I'll let the surgeon answer about letting computers do his job. At least for
if we in diffuse type tumors, you never will reach the last cell. Never. You never will reach the last cell because there is no clear separation. There I have to be honest. And for me, up to now, I would not see how artificial intelligence may help. Perhaps this is a discussion in surgical oncology, fluorescence markers or something else that we perhaps in a few years you can marker the cell. But then no, this is wrong because here you have only the cell, the reactive cell you will not have. This is the problem. If I would have an Ewing sarcoma cell, perhaps I can mark it and I see in the operating theater, oh, there is an immune fluorescence or something else. But in these tumors, the cell which causes the harm is only one and the rest is reactive. And how should I separate this surgically and even with other markers? I think it's difficult.
And also, it's the problem is the therapeutic window. So in osteosarcoma and Ewing sarcoma, we are need to accept amputation or wide resection with margins because we know that if a single cell is left behind, you can die. So, but with a benign disease, nobody would give a young patient some important morbidity to get that cell out. So it's a very philosophical problem linked to the benign nature of this tumor.
I think what you'll learn here also is that just because you have the disease doesn't mean you need to treat it. So that's the big difference between cancer, right? So just because it's there doesn't mean it has to be gone. Many of us, like I've been off treatment for 4 years, active surveillance. Yeah, so I think everybody's a little different, but just because it's there doesn't mean it has to be gone. So I think that's what makes artificial intelligence a little, like, how would you differentiate between what needs to go and what doesn't? So there has to be some amount of human interaction. As a human, I'm going to say that and keep my job.